Chapter 40, Disorders of Endocrine Function. So in this chapter, we'll talk about the hypothalamus as it controls the release of a lot of hormones, and then we'll specifically focus on thyroid hormone and parathyroid hormone. So a lot of our hormones are released through the hypothalamus and pituitary. So hormones that are released from the hypothalamus are typically known as releasing hormones. They will then travel to the pituitary. In this case, we're talking about the anterior pituitary, and it will travel through the hypothalamic hypophyseal portal system that connects the capillary bed in the hypothalamus to the capillary bed in the anterior pituitary. The anterior pituitary has endocrine glands, so the releasing hormone will stimulate the endocrine glands in the pituitary to release the next hormone. Typically, these are known as stimulating hormones. Here we have tropic hormone. Tropic hormones are just hormones that will then cause the release of another hormone. And so these tropic hormones will go to the peripheral gland and release the final hormone. And hormones are under negative feedback. So as our hormone levels rise, we have negative feedback back up to the anterior pituitary and the hypothalamus. And this helps to ensure that we have balance. So what kind of endocrine disorders can occur? So typically, when we have an endocrine disorder, it's either we are making too much hormone, hypersecretion, too little hormone, hyposecretion, or it could be we have an issue with the target tissue not responding appropriately. So the changes in hormone secretion, whether we're hyper or hyposecreting, can occur at the level of the hypothalamus or the pituitary. And if the issue is at the level of the hypothalamus or the anterior pituitary, this is known as a secondary pathology. If the issue is in the peripheral gland that releases our final hormone, then that is a primary pathology. So our hormone level is high, let's say, because we have a tumor in the hypothalamus. So there's really nothing wrong with our gland. It's that our gland is making too much hormone because the hypothalamus has the issue. So it's a secondary pathology. So what can cause these endocrine disorders? So etiology could range from a congenital issue where you're born with it. It could be due to an infection, whether we're talking about a viral or a bacterial infection. And then it could be an immune issue. So autoimmune system having an impact on our hormones, or it could be cancer related, so neoplastic. And then we have idiopathic. It's spontaneous, or where we don't know what the cause is. And then we have iatrogenic, which we said is physician caused. So for example, you're getting treatment and that treatment therapy is causing the disorder in endocrine function. So here is a nice figure that kind of goes over the release of hormones through the hypothalamus. And here we see both the anterior and posterior pituitaries. So the hypothalamus will secrete oxytocin and ADH, or vasopressin, through the posterior. So we have these cell bodies of our neurons in the hypothalamus that will produce these hormones. It will travel through the axon to the posterior pituitary, where it is then released from the posterior. The anterior pituitary, again, requires the hypothalamic hypophyseal portal system, and we can see that here, the capillary bed here in the hypothalamus connected to the capillary bed here in the anterior pituitary. So we'll actually release the hormone into the bed of capillaries from the hypothalamus. It'll then travel to the anterior and cause the release of our tropic hormone, or our stimulating hormone. And again, the hypothalamus releases our releasing hormones. And then the anterior pituitary hormone will then stimulate the endocrine gland to release the final hormone. Now, one difference is growth hormone. Growth hormone is actually directly released by the anterior pituitary. But other hormones like FSH and LH, follicle stimulating hormone and luteinizing hormone, will stimulate our gonads to either make gametes or produce our sex hormones. Then we have thyroid stimulating hormone, which will go to the thyroid gland and stimulate the release of thyroid hormone. And then we have our adrenocorticotropic hormone, which will go to our adrenal cortex and cause the release of cortisol. Today we're going to focus on thyroid hormone. So thyroid hormone is stimulated by sleep, cold temperature, stress, These can cause the hypothalamus to release TRH. So again, thyrotropin releasing hormone. Notice the hypothalamus tends to release hormones called releasing hormones. It will go directly to the anterior pituitary and cause the release of TSH, stimulating hormone. So thyroid stimulating hormone, which will do what the name says. It'll go to the thyroid gland and stimulate the release of thyroid hormone. Now, thyroid hormone is released as T3 and T4, but T4 will lose an iodine and then turn into T3. And T3 is our thyroid hormone that's going to act on our target organs. And here we see our negative feedback, which again helps to regulate our hormone levels. So again, what does thyroid hormone do? It really stimulates metabolism, and so that's what T3 is going to do. So here we're looking at what happens when we have a lack of iodine in our diet. Now, iodine is necessary to produce thyroid hormone. So we make thyroid hormone in our thyroid gland with iodine. And so let's take a look at what would happen if we have an iodine deficiency. So when you have a lack of iodine in your diet, you don't have that iodine substrate to make thyroid hormone. So your thyroid hormone levels are going to be low. Your T3 and T4 levels are going to be low. That means we're going to have an absence of negative feedback. And so our hypothalamus will actually release TRH, which will stimulate the anterior pituitary to release TSH, which will stimulate the thyroid gland to release thyroid hormone. The only problem is we don't have the iodine to make thyroid hormone. As a result, thyroid hormone levels remains low, so we have that absence of negative feedback. So this downward signal basically continues. And so what we're doing is we are constantly stimulating our thyroid gland. And when we constantly stimulate our cells, it can start to grow, and that's how we can develop a goiter. So this is an example of how we can have a goiter with hypothyroidism, so low thyroid hormone. So what exactly does thyroid hormone do? What's its role in the body? Well, thyroid hormone affects the quality of our life, meaning we will not perish without it, but our quality of life can be impacted. So it has a role in metabolism, so it speeds up our metabolic rate, it speeds up protein synthesis, and with that increased metabolism, there's going to be increased cardiovascular function, so increased oxygen consumption, increased respiratory rate, increased blood volume, cardiac output. We'll also enhance our GI function, have greater appetite, and because we have increased metabolism, it'll be difficult to gain weight even though we have a bigger appetite because we'll be burning so much. It's also necessary for normal growth and development in children, and we're talking both about mental development and sexual maturity. So if you don't have thyroid hormone, these can be impacted. Thyroid hormone is also involved in myelin and synapse formation. It also enhances neural control of things like our muscles, helps them react more vigorously. So I like to think of thyroid hormone as really just turning our body on. So the engine of our body, just everything kind of gets stimulated and turned on. So let's discuss hypothyroidism. So hypothyroidism, low thyroid hormone, can be congenital, so something that you are born with. It affects about 1 in every 5,000 births. And these infants will actually appear normal at birth, and that's because they will have the mom's thyroid hormone while they're in utero. If it's left untreated, it can lead to a condition called creatinism, which is a preventable form of diminished mental capacity. Remember, thyroid hormone is essential for normal growth and development, including brain development. So why is it preventable? Because if it is found that an infant lacks thyroid hormone or enough thyroid hormone, then we can give exogenous thyroid hormone. So it can be prevented. We can also get hypothyroidism through acquired means, so you're not born with it. So the first one is Hashimoto's thyroiditis, which we'll talk about next, has to do with the immune system. And then if you have a thyroidectomy, have the thyroid removed, or we saw how iodine deficiency can also lead to hypothyroidism because you don't have the substrate to make thyroid hormone. So acquired thyroid hormone, you're not born with it, so it develops later in life. because of a primary disease of the thyroid gland, or it could be secondary to other disorders. And because we know that thyroid hormone basically increases metabolism, I said it just turns on the engine of our body. Not having enough is just going to do the opposite. Everything's going to slow down. So we'll have a slowing down of our metabolic processes. It'll cause things like weakness, fatigue. You'll have a tendency to gain weight even though you have a loss of appetite. And so it makes it difficult to lose weight. You also have cold intolerance, brittle nails, thin hair, dry, thin skin, slow heart rate, bradycardia. The most common cause of hypothyroidism is Hashimoto's thyroiditis, and this is an autoimmune destruction of your thyroid gland. So you can kind of think of it as this is the type 1 diabetes of the thyroid hormone or the thyroid gland. So we talked about hypo, let's talk about hyper. And an example of hyperthyroidism can be seen in Graves' disease. So Graves' disease is an autoimmune disorder, but it's a little bit different than what we're used to seeing. So typically when we talk about autoimmune disorders, it's where the immune system is destroying, like Hashimoto's thyroiditis. But in Graves' disease, the immune system doesn't destroy. Instead, our immune system is going to make an immunoglobulin. Remember, an immunoglobulin is an antibody. And this antibody is called thyroid stimulating immunoglobulin, so TSI. And TSI acts exactly the same as TSH. So thyroid stimulating hormone normally stimulates the thyroid gland to make thyroid hormone. Well, TSI acts exactly the same way, so it will also stimulate the thyroid gland to make thyroid hormone. So we have created these antibodies that act like TSH. Now, when these antibodies, TSI, stimulate the thyroid gland to make thyroid hormone, our thyroid hormone starts to rise. That increase in thyroid hormone is going to produce a strong negative feedback back up to the anterior and hypothalamus. And so the hypothalamic release of TRH will reduce. The anterior pituitary will start to decrease the release of TSH. So we'll see a low TRH and a low TSH level, and yet thyroid hormone levels will be high. And that's because this TSI is not regulated by negative feedback. So these antibodies will constantly stimulate the thyroid gland to make thyroid hormone, leading to hyperthyroidism. Also, since we're constantly stimulating that thyroid gland, it'll actually enlarge as well. And so we can also see a goiter in Graves' disease. So a goiter is not just related to hypothyroidism. We can actually see it in both. With Graves' disease, we'll also see a condition called exophthalmos, which is the bulging of the eyeballs because of the way that it affects the tissues around the eye. Now, we can also see hyperthyroidism not just with Graves' disease, but also a tumor in the thyroid gland. And we talked about how tumors, again, tend to produce too much hormone. So if you do have hyperthyroidism, what will the manifestations be? Well, it's basically going to be where you turn on the engine of the body too much. So everything is going to go really fast. So we'll have increased oxygen consumption, increased sympathetic stimulation. You'll be nervous, irritable, fatigable. You'll have weight loss despite large appetites. Or another way of looking at it is you'll have difficulty putting on weight. You'll have tachycardia, increased heart rate, shortness of breath, excessive sweating, muscle cramps, and instead of cold intolerance, you'll have heat intolerance. And we can see some of the signs and symptoms here in this image. So a woman has a benign pituitary tumor, and she's lost weight. She complains of being hot all the time, and she presents as thin and nervous. She also has tachycardia and exophthalmos. So looking at her signs and symptoms, what hormones are being secreted by the pituitary tumor in this patient? It says these patients, but it's a woman, so in this patient. So looking at her signs and symptoms, it kind of looks like she has too much thyroid hormone. So the pituitary will actually be releasing too much TSH, which is then going to the thyroid gland and stimulating the release of thyroid hormone. So her signs and symptoms are indicative of hyperthyroidism. So now let's move on to parathyroid hormone. So parathyroid hormone, to review, is related to calcium. So let's review calcium. So to refresh your memory, normal levels are between 8.5 to 10.5 milligrams per deciliter. We know extracellularly that calcium can block our sodium channel, so it can really affect our nerve and muscle cell firing. It's also involved in blood clotting, and we know it's involved in all muscle contractions, including skeletal muscle, smooth muscle, cardiac muscle. And it can also act as a second messenger. So we know at the end of a neuron, for example, extracellular calcium entering into the terminal stimulates exocytosis of our neurotransmitter. Now, a hormone that's quite important for calcium balance is parathyroid hormone. So parathyroid hormone is released by the parathyroid gland. You find 4 of them on the back of the thyroid gland. And basically, parathyroid hormone raises blood calcium levels, and it does it 3 ways. So calcium levels can be altered or regulated either by the bones, our kidneys, or our intestines. So let's go through that very quickly. About 99% of our body's calcium is stored in our bones. So it makes sense that our bones are going to play a pretty big role in blood calcium levels. When we break down our bones, it causes calcium to be released from the bone into the blood. So it's a way to raise blood calcium. When we build bone, we take the calcium out of the blood and put it into our bones. In terms of our kidneys, what does it do with calcium? Well, we actually filter calcium in our kidneys. And so if we reabsorb it back, then we're going to retain the calcium that we have in our blood. If we don't reabsorb it, then it's just going to be lost in urine. And so it's a way to eliminate calcium from the body. Now, what do the intestines have to do with calcium? Well, the foods that you eat can have calcium in it. And so eating and then obviously absorbing the calcium will increase blood calcium, and not absorbing it will keep it low or not elevate it. So parathyroid hormone raises our serum calcium level. So it raises blood calcium level. So knowing that, it's pretty easy to figure out what happens in each of these areas. So what would parathyroid hormone have to do to our bones to raise blood calcium? It would have to cause it to break down so that calcium is released from our bone. So it'll activate our osteoclasts, which are our bone breaking cells. Parathyroid hormone raises blood calcium. So what do you think it'll do to the kidneys? It will obviously then cause the calcium that we filter to be reabsorbed. And that way, will eliminate less calcium in our urine, which will help keep our blood calcium elevated. And parathyroid hormone will also impact our intestines, but notice it doesn't do it directly, it does it indirectly. So parathyroid hormone will also stimulate the kidneys to make activated vitamin D, and that activated vitamin D allows us to absorb calcium in the intestine. This is why a lot of the times when you find calcium, you see it with vitamin D3. And so the more calcium we absorb in the intestine, the higher our blood calcium levels. So this is just another way to look at the same thing. So parathyroid hormone can impact our bones, breaking them down, affect our kidneys, causing us to reabsorb calcium, and then it affects our GI tract, causing us to absorb the calcium. And it does that, again, by activating vitamin D3 through our kidneys. So let's talk about having too much and too little. Parathyroid hormone. So hypoparathyroidism would be too little parathyroid hormone secretion. So if we know that parathyroid hormone raises blood calcium, not having enough will result in low blood calcium, which is hypocalcemia. Emia blood, hypo low calcium. So this may be due to a congenital absence of the parathyroid gland. So some people are born without a parathyroid gland or without parathyroid glands, and so this is known as DeGeorge syndrome. Or it could be acquired, maybe after neck surgery it was removed. Or it could be an autoimmune destruction of the parathyroid gland or due to an infection, or it could be due to magnesium deficiency, as magnesium is necessary for parathyroid hormone production. So if you do have hypoparathyroidism, and as a result low calcium in the blood, it's going to lead to things like tetany and muscle cramps and convulsions. So think about calcium here. Remember, calcium, we talked about this previously, can block sodium channels. And so not having a lot of calcium means less sodium channels are blocked, so we have increased kind of action potentials. It can also lead to hypotension, drop in blood pressure, lethargy, anxiety, and personality changes. So if we have hypo, we can certainly have hyper. So hyperparathyroidism means too much parathyroid hormone is being secreted. And so that's going to lead to increased calcium in the blood, so hypercalcemia. Now, this can happen due to a primary or secondary reason. So, primary hyperparathyroidism is a common disorder and it's just due to hyperplasia of the parathyroid gland, and so it's making too much parathyroid hormone. Secondary hyperparathyroidism also involves hyperplasia of the parathyroid gland, but it's due to renal failure. So, because you have renal failure, you're not activating vitamin D, so you're not absorbing calcium in the intestines, which means calcium levels are going to be low. So then your body will release a lot of parathyroid hormone to raise blood calcium. So notice it's not the parathyroid gland that's the issue, it's the renal failure that's the issue. And so it's a secondary disorder. So if we can fix, obviously halt renal failure, get treatment, or get vitamin D3 so that we can absorb the calcium, then the excess secretion of parathyroid hormone will be resolved. So manifestations, again, we'll have hypercalcemia. All of that calcium in the blood can eventually show up in your urine, which can increase the likelihood of kidney stone production. And because you have a lot of parathyroid hormone, you're obviously going to be impacting our bones. So it'll start to break down our bones, causing demineralization and increasing the likelihood of fractures and lesions and just skeletal abnormalities. And that's it for this chapter. Thank you.